Welcome to everyone. I see that people are joining our webinar, so we will give it like maybe 30 seconds so everybody gets a chance to join us today. In the meantime, my name is Razumova, medical doctor from Sweden, and today I have a pleasure to moderate very new version of ENAGAGE webinar, new format, and that's going to be in the format of virtual Onco-Care unit. So we will go through different different parts of the hospital together with our experts and together with my colleague and friend, Olivia.
Good evening and welcome. My name is Olivia, and today I will guide you through a virtual comprehensive cancer care unit dedicated to ovarian cancer. Together with Dr. Zoya Razumova, our moderator, we will take you on a 120-minute guided tour through the ovarian cancer pathway, from first symptoms and prevention to diagnosis, treatment, support, rehabilitation, and follow-up. This is not a traditional webinar. Today, each part of the program is a room in our virtual Onco-Care unit. In each room, we will meet experts, patient advocates, and people with lived experience. We begin in the patient admission area, where 3 women have arrived. Their stories will help us explore different moments in the ovarian cancer pathway.
Thank you so much, Olivia. That was a nice introduction. It's great to have friends who help you with voiceover, right? And we continue. We are going to meet 3 patients today. Probably going to get a feeling like you already know this women because their stories are quite familiar to many of us. Those doctors who are listening to us probably met such patients before, and those survivors, patients, and patient advocates who are listening to us probably also met such people. Yeah, we have 3 ladies today with us. They are different age and different region, have different stories. So the first lady is Fiona. She's 62 years old, still working. Unfortunately, since some time back, she got a persistent pain in her stomach, so that we call abdominal pain. She also feels like she's bloated, and beside that, she had the story of her mother. She lost her mother due to breast cancer. So she's really worried about this situation, of course. The second patient is Sophie. Sophie is 42 years old, have few kids. She has no known family history of ovarian and breast cancer, but she has been experiencing fatigue and loss of appetite. So her quality of life is really like struggling. She has several examinations at her at the doctor's office, but she hasn't yet met any gynecologist. Probably she's gonna do it today, right? We'll see. No spoilers. The third patient is Tessa. Tessa is 48 years old. She was studying the same school as Sophie. She is the mother of 3 children. That's a lot to do, right? She has no symptoms. But her mother had breast cancer, and her grandmother even died of ovarian cancer. So she wants to understand her risks. She wants to reduce this risk if it exists. So let's see whether we'll be able to help her today. So please come with us and Fiona, Sophie, and Tessa to the next room. And we are going to accompany them today through the whole journey of our virtual Onco-Care unit. So we move further. Waiting rooms. It might be a huge emotional weight of uncertainty. I think all of you, even those who are oncogynecologists and other specialists who are here with us today, you're all been patients at some point, and you know how emotionally hard it is to sit and just wait and not knowing what's going to happen and what is waiting next. So let me introduce you once again to this waiting room. You see, it's like few sofas, pretty like comfortable atmosphere, but those patients waiting to be called in. It can be emotionally difficult, as I already mentioned, and there is no diagnosis yet. But those patients already feel that can be wrong or can go wrong. So therefore, it's very important to support them at this point. Therefore, I invite on the stage, or like you're going to meet our psychologist, Stephanie. Stephanie is going to speak about the psychological experience of waiting, fear, and uncertainty. How is it to just sit there and wait? And how maybe you can handle the situations. So welcome, Stephanie. The stage is yours.
Thank you, Zoya. Good evening, everyone. Thank you very much for the invitation. Today, I would like us to focus on a phase of the cancer journey that is often clinically brief, but psychologically extremely significant. As Zoya said, the waiting period before diagnosis. Hopefully it works. Okay. So, entering the waiting room, the moment patients enter the waiting room, something important often happens psychologically. They're no longer simply attending an appointment or waiting for tests. They are beginning to confront the possibility that life may change. And this psychological shift frequently happens before any diagnosis is confirmed. So patients often describe feeling suspended between two realities, the life they knew before and a future they are suddenly afraid to imagine. And in psycho-oncology, we know that uncertainty can become emotionally overwhelming precisely because there are still no clear answers. And the mind begins to wander, searching for meaning, examining different scenarios, interpreting symptoms in a different way, asking ChatGPT for what's wrong with me. And alongside, patients still continue to work, caring for family members, attending daily responsibilities while internally experiencing fear, anxiety, loss of control. So even before a diagnosis, people are already carrying significant psychological burden. And it's a very key concept in psychology, the intolerance of uncertainty that is not experienced passively by the human brain. It is describing the extent to which uncertain situations are experienced as stressful, threatening, and emotionally difficult to tolerate. And this is highly relevant in oncology settings because during diagnostic waiting periods, patients are often confronted with a situation that feels emotionally significant, potentially threatening, and very unpredictable at the same time. So psychological research shows that uncertainty itself can become a major source of distress even before diagnosis. And why waiting could feel psychologically overwhelming? Because as human beings, we're biologically and psychologically wired to seek predictability, meaning, control. When something potentially threatening is happening, but answers remain unclear, the brain enters a heightened state of alertness. And this is why patients waiting for results are often experiencing intense anxiety, even before confirmation of illness. And uncertainty is not the absence of information, it is an active psychological state. And coming from the psychology perspective, it activates the threat perception system. So the brain continuously searches for meaning, prediction, and safety. So sometimes patients have incomplete information, such as a suspicious scan, an abnormal finding, a biopsy pending, a delayed phone call. And in these moments, the mind naturally begins constructing possible futures. And these are a few signs which we don't have the time to go into detail, but in clinical practice, this is what we usually observe as signs of uncertainty. And sometimes this emotional experience remains hidden, and this is why communication and emotional support during the waiting period matters greatly. Even when healthcare professionals cannot yet provide definite answers, they can still reduce this distress through clarity, empathy, structure, and presence. So you can see the impact on the emotional and the cognitive and on the physical side. So the waiting room is where the fear first becomes real. And I think it is important to reflect on the symbolism of the waiting room itself. And we can see it as a psychological space where in oncology settings, waiting rooms are often emotionally charged spaces. And patients observe others, they interpret facial expressions, they listen for names being called, they attempt to read meaning into delays or staff behavior. And psychologically, this environment can intensify anxiety, and silence can become very powerful. And this emotional duality is exhausting. So what helps patients during this period? And I cannot stress this enough that psychological support should not begin after diagnosis. Patients benefit enormously from psychological containment during uncertainty. And often what reduces distress is not having immediate answers, but having structure, having guidance, having human connection. And simple communication matters, explaining what happens next, clarifying waiting times, acknowledging emotions openly. And patients cope better when uncertainty feels shared and than faced alone. And even brief moments of empathy can regulate anxiety. And this is where multidisciplinarity care becomes very important, and support should not only be medical, but relational and more holistic. And healthcare professionals can acknowledge uncertainty with honesty and empathy, provide psychological containment as mentioned earlier, try to maintain clarity and transparency as much as possible, and try to sit there with the feelings of patients, reducing therefore feelings of abandonment and isolation. And patient advocates also play a uniquely important role, and advocates often help bridge the space between clinical systems and lived experience, and they normalize emotional reactions, they reduce isolation, and they help other patients feel seen beyond the diagnosis process. So for many patients, feeling emotionally accompanied during uncertainty can become just as important as the medical information itself. So to conclude, it is important that we recognize the diagnostic waiting period as a clinically meaningful and significantly psychological phase within the cancer care. And for patients, this is not a period where nothing is happening. It is a period often of intense emotional processing, fear, vulnerability, loss of control. And long before treatment begins, many patients are already carrying significant psychological burden. And finally, while healthcare professionals may not always be able to move within uncertainty immediately, we can influence how patients experience this uncertainty through communication, through presence, through psychological safety, and through ensuring that patients do not feel alone while waiting for answers. Because sometimes the most distressing part is not yet knowing what comes next, and those moments, compassionate human connection becomes an essential part of care. Thank you very much for your time.
Thank you very much, Stephanie. It's very important to highlight your role in the patient's journey. It is unfortunately often underestimated in some areas, even in Europe. So we'll try to highlight it. Thank you for that.
Thank you very much.
Olivia?
Another door is opening. One of our patients, Tessa, is being called in to discuss her family history and prevention options.
So Jürgen, it's your turn. Please guide Tessa and all of us, of course, through what she and us needs to know.
Well, thank you, Zoya, for the nice introduction. The interesting thing is, and I might be a party pooper, is that we all talk about ovarian cancer, but it's now clear that most ovarian cancers are actually not derived from ovarian cells, but from fallopian tube cells. So that's the organ that goes from the uterus to the ovary. So I will show you here. I cannot move my slides. Oh yes, here. This is the anatomy. Over here you see the uterus. This is the female pelvis, the uterus with the fallopian tubes. And here you see the ovaries. And it'll be a bit more close. If there is a follicle where a ripening follicle where an egg comes out of, it goes through the fallopian tubes inside the uterus, and when it's fertilized, it nestles here inside the uterus. Well, first, the idea wasn't that this idea was for several years, maybe 100 years. It was that cells on top of the ovary, that are cells that look very simple under the microscope, they get after an ovulation. So when you've got the egg that ruptures out of the ovary, you've got a wound over there, and then you've got a little hole in the ovary. And the idea was that these cells enter the ovary and become, in a certain process, look a bit like cells that you normally see inside the fallopian tube. And then in some cases, these cells could become cells that look a bit like cancer, but are not cancer yet, and eventually it can become carcinoma or cancer. That was the initial idea. But then in the 90s, some women with a high risk due to their family, like our patients, they were starting to test them on certain genetic changes, and they found certain genetic changes on DNA in specific regions, and this DNA codes for proteins that are they have a function in the reparation of DNA damage. So these women do have a high risk on cancer of the ovaries and breast cancer. Well, I started to do my PhD thesis, and here you see such an ovary, and here you see the fallopian tube that goes around it. And I started to culture these cells in the laboratory. Here you see that you've got medium in which we culture them, and we culture them in flask. And what that means is that you put these cells in this medium, there's food in there, you put them in these flasks, and these flasks will be in an incubator where it's 37 degrees Celsius. And then when you look through the microscope, we saw in these scrapings, we saw ovarian-like cells, and we saw cells that look like those fallopian tube cells. So why did we first think about the ovarian cells as origin for ovarian cancer, and now the tubal epithelium, so these tubal cells? Well, because women at this hereditary high risk, like our patients, when they have a proven mutation in these high-risk genes, can undergo prophylactic surgery. And during this prophylactic surgery, you remove the ovary, but also the fallopian tube. And together with Professor von Diest, I started to look through the microscope at these fallopian tubes. And of course, you see a little part of the ovary. And much to our surprise, this is a normal fallopian tube lining. So this is through the microscope, very small layer of cells in the fallopian tube. We saw this is a normal situation. And here you see that this is not one layer of cell, but this is more cells on top of each other. And this is a lot of layers. And this is what we call a situation in which is virtually cancer, but it's not yet because it's not breaking through the certain basal membrane. But much to our surprise, in these prophylactic removed fallopian tubes, we saw a high incidence of these preneoplastic lesions. And we also saw that I was talking about these genes that give this high risk. These genes were also, the normal genes were also away. So this was like really precancerous lesions. So then I started to flush these fallopian tubes with just salt. So I was mimicking something like the menstrual blood flow. Normally menstrual blood flow goes through the cervix outside, but also a little bit inside. So we were mimicking this, and we put this in culture. And what we saw were these cells that look very much like tuboepithelial cells. But I told you already that we also were scraping these ovaries, put them in culture, and we saw these ovarian cells, but we also saw these cells that look very much alike the fallopian tube. And this is again the picture you previously saw. This is the lining of a fallopian tube microscopically. So this is one layer of cells, and this is a normal situation. So this is not piling of these cells. Inside the ovary, sometimes you see these inclusion cysts, they mimic very much how it looks inside the fallopian tube. So we question ourselves, are these cells here in the ovary really from the ovary? So is that process I described in the beginning, that these simple cells become very differentiated, is that true? Or are they actually derived from the fallopian tube? Well, since the most common form of ovarian cancer has the serous histotype, that's a way it looks like through the microscope, and since the most common form of tubal carcinoma has exactly the same look through the microscope, it's only per definition when there's more tumor in the fallopian tube we talk about tubal cancer. And since here you see the microscopic appearance of the fallopian tube again, and here you see the ovary. And after there was a follicle rupture, so after the ovulation, here you see the ovary with this follicle, this rupture. And of course, you can imagine this bloody situation. And if there is some loose tuboepithelial cells, they of course can just go on side there and start to grow over there. So what we previously said, serous ovarian carcinogenesis, it's not ovarian, but it's tubal, because we believe that these tubal cells, they got included inside the ovary and became pre-neoplastic and eventually also cancers. And nowadays we also know that it quite often happens in the fallopian tube, and then it grows towards the ovaries. Well, we published several papers on this topic. There was a lot of discussion within the scientific community. People said, yeah, this is dumb, this is not true. At first we were not believed. So we published certain papers on this topic. And then finally, the group of Christopher Crum from the United States, they found also a high incidence of these precancerous lesions in the fallopian tubes and not in the ovaries. And the same counts for the group of Leming Shi and Robert Koorman. They also had the same kind of observations. Well, to finally summarize it, you all know these graphs. These are 10-year survival curves from women with ovarian cancer stage 3 and 4 in the Netherlands. And it's actually ovarian and fallopian tube cancer from 85 till 2023. And you see that the 5-year survival rate has not really changed significantly, despite the fact that we have PARP inhibition and we have got HIPEC nowadays. And that's why we sat together with a whole group of people, and some of them are talking tonight as well, from the ESGO, to discuss the opportunity of a salpingectomy for the prevention of tubal ovarian carcinoma in women at normal risk for tubal ovarian cancer. I'm not talking about women with a hereditary high risk. So I'm not really talking about these patients we just were talking about. But if women do undergo surgery for other reasons, for example, because they get a hysterectomy, or for example, they get a cholecystectomy because of gallbladder stones, then you might also discuss the option of also removing the fallopian tubes. Another word for that is salpingectomy. And we call that the opportunistic salpingectomy. And actually, large cohort studies show a really decreased risk of ovarian cancer in women who've had this so-called opportunistic salpingectomy. So that's what I would tell the patients that are inside my my speaking room. Thank you.
Thank you very much. Thank you very much, Jürgen. I think we have a very typical situation here when in the middle of appointment, there is a doctor's phone call, right? So you really feel like at the real hospital. So thank you, Jürgen. You're a rock star in this field. And I think it's such a luck we have today that we have the best experts from all over the world in one hospital. That's a dream hospital that I would really want to work at, actually. So Tessa now has the information about her risks and what to do, and she can discuss those options with her family, maybe even inform her daughter, who is already over 18 years old, so they can discuss those options together. And maybe she will also visit Jürgen later. And we will continue with Fiona and Sophie. I hope you still remember that. Who unfortunately do symptoms. The one is feeling very tired, like those general symptoms, let's say, and the other is very bloated in her belly. So we will continue with them and move to the diagnosis room. That's the place where we really can help to give a diagnosis or maybe to exclude a diagnosis. So we are entering this diagnostic room together with those two patients. And Dr. Zoltan from Hungary, who is also a big friend of ENAGAGE, is going to present now and talk about, he will explain us what is ovarian cancer, how to make this diagnosis, and what happens next.
Thank you. Thank you, Zoya. It's a pleasure to be with you and to be in this excellent hospital full with wonderful experts, really a dream hospital. So what are from the first symptoms to the first treatment decisions? That is the goal of the diagnosis. If we are making a good diagnosis, that's one of the most important keys for successful treatment. So how do we do that? And I would like to invite Fiona and Sophie into the consultation room. I need to click on it, I think. Yeah, doctors has to show also vulnerability. So I cannot really deal with this with the presentation. Good, great. So as you all know, that ovarian cancer, what was nicely presented by Jürgen, my friend who is doing the night duty in our hospital right now, is that this means that cancer starting in the ovary or in the fallopian tube or in the lining of the abdomen or so-called peritoneum. These three are often managed together because they behave similarly. And usually patients are diagnosed with this disease in quite late stage. So around 70% of our patients arrive when the disease is already in an advanced stage. So we have to tell them that it's not unique. They are the typical patients, but early recognition and fast referral can make a real difference, because look at this picture. That is usually what we see on the face of Fiona: anxiety, stress, and maybe the fear of facing one of the worst sentences in her life to have a diagnosis of a cancer. So this the ovarian cancer has 4 stages, and the first 2 stages are considered to be the early stage diseases, and when the disease is confined, is localized to the ovary or the surrounding pelvical organs. And in stage 3, it is spread already in the abdominal cavity, and stage 4, it's spread outside of the abdominal cavity. So usually the majority of our patients arrive in the 3rd stage, when they have already metastatic spread disease in the abdominal cavity. It can touch the intestines, the surface of the liver, the surface of the diaphragm, and many other organs in the abdominal cavity. So if we return back to our patient Fiona, who is 62 years old, has a family history of breast cancer, we always need to, with doctors, we always need to start with the history, asking about the history, family history, personal history. And it's quite an important fact that she had, I think, a mother who had breast cancer, and her symptoms are very typical to advanced ovarian cancer. But you have to, these symptoms like bloated abdomen, increasing abdominal size, pelvic abdominal pain, feeling full quickly, all these pain, symptoms can be typical for ovarian cancer, but these are not specific. So we have to first start by saying that most people with these symptoms do not have ovarian cancer, but we are in our hospital, this is a cancer hospital. So most probably Fiona has already had a gynecologic exam and they found something. That's why she was referred to our unit. And so if we are speaking about diagnosis, we use different tools. We used imaging, and imaging is not perfect. If you look at this Nokia phone, we have sometimes the same situation in imaging. The reality is much different than what we can see on the pictures. And CT scanner, all these imaging tools are not perfect. They don't detect the small amount of disease, and they are not sensitive enough, and sometimes they are not specific enough. So they can detect something which is not cancer. The same is for the tumor markers. Tumor markers are blood tests, and they have limited use because they are specific. You have to keep in mind that just doing a simple tumor marker, if you don't have symptoms, if you don't have a disease, it's most probably useless, because tumor markers can be increased also in case when there is no cancer in the body. So we can do a minimal invasive operation, laparoscopy, just to look inside the abdomen. And it's a very precise, precise technique, but of course it is an invasive technique. And more we use, however, our golden technique, the biopsy and the histologic confirmation. So we need to, if we want to know for sure if it is a cancer or not, we need to confirm it by histology, by taking a biopsy and sending it to pathology, which is going to give us a lot of very detailed information about the subtypes of the cancer. Even molecular diagnostics can be done, and then we can analyze the fingerprint of the tumor. So we had a wonderful consensus statement a few years ago between different scientific bodies, and there are recommendations how to follow the different diagnostic steps in different situations. For example, in Sophie's situation, who is 42 years old and have suspicion of an ovarian cyst, it's for sure, it's not ovarian cancer, it's not proven. So we have to follow this. If there is an ovarian cyst there, we need to do an ultrasound, usually by transvaginal ultrasound. We can use scoring system to be less subjective, and we can estimate the risk of malignancy, how high is the risk that it is a cancer. And depending on the risk of the cancer, our follow-up is different. If the risk of cancer, ovarian cancer, is bigger than 10%, then we need to refer the patient to a specialized gynecologic cancer unit. And in the specialized gynecologic cancer unit, then we can follow the following steps. We start also by ultrasound with these scoring systems, but we can also do MRI, do a lot of tumor markers. We can do a lot of tumor markers in specific situations. And with the leadership of a gynecologic oncology specialist, we can differentiate between borderline tumor, so which is not a very dangerous ovarian tumor, early stage primary ovarian cancer, advanced stage primary ovarian cancer, like stage 3 and 4, or metastatic ovarian cancer, when the disease comes from another site, like gastrointestinal cancers metastatizing for the ovaries. All of these diseases have to be treated differently. So this is very important for our treatment decisions. And you know, and I'm not going to speak about treatment, but you know that surgery is one of the most important cornerstone treatments of the ovarian cancer treatment. And the first major decision we have to make, mostly if we are speaking about an advanced stage ovarian cancer, then which is the majority of the ovarian cancers presenting in our cancer care unit, shall we start with the surgery first, or shall we start with the chemotherapy first and continuing with the surgery later on? And that's a very difficult question. And for this decision, we need to collect a lot of information. As you can see here, it's our brand new recommendation presented in ESGO 2026 conference that even the histologic subtype of the tumor is going to make difference between if we choose primary surgery or if we choose primary chemotherapy followed by surgery. So altogether, summarizing these facts, the information we need: is it malignant? Ultrasound is going to help. MRI can help. Tumor markers can help. And of course, biopsy histology is the golden solution to answer this question. What is the stage of the disease? How spread it is? Usually we use CT, diffusion-weighted MRI, or PET-CT, or we can use also laparoscopy, which is very precise, but it is invasive. Is it primary ovarian, or it is metastatizing from another organ to the ovaries? For that, we can do a biopsy. We can do biopsy while being in the operation room, for example, with a laparoscopy, or we can do a biopsy. I'm going to show you the technique which we use, and I could say that Roman is going to maybe show it in details. And biopsy is also going to tell us a lot of precise information about the histologic subtypes and about the molecular fingerprint of the tumor, which is going to influence our decisions later on. So altogether, speaking about the biopsy, which is the golden diagnostic method, we can do it by laparoscopy, which is an invasive technique, or we can do it by CT-guided or ultrasound-guided biopsy. And you can see here that transvaginal ultrasound-guided biopsy is an excellent modality. We use a small needle attached to the transvaginal probe. We can do it very quickly. And so we have the histologic, the biopsy confirmation very when the patient, in a few days, from the time when the patient enters. So we can make a decision very quickly in relation to the histologic subtype of the disease. So I think that's all. We need also to pay in this room of diagnosis. We need to be masters in the art of communication. This is one of the most important facts. The patient arrives with a lot of anxiety, is going to be struck by the lighting of this diagnosis. So we need to show empathy and really practice our most important human characteristics like empathy. So thank you very much, and thank you for the invitation and being part of this hospital.
Thank you very much, Zoltan. Of course, you're a part of this hospital. You're an employee, right? So we are happy to have your talk today. Now Fiona and Sophia know what to do, and they completed their imaging and diagnostic tests. While we wait for the full treatment, participants, there is a poll on your screen where you can answer to a question. What do you believe is the biggest concern about ovarian cancer treatment? And then there are different options, and you can also write a short answer that you think doesn't exist in the list we provided. If you feel like this complicated system doesn't work, you can also send your comments in the comment box. So let's wait for the result. In the meantime, I've noticed that some of you are very, very active. Thank you very much for asking the questions in the chat box. Today, we are very busy at the hospital and unfortunately do not have time for some extra activities. However, we are happy to answer your questions later. you can approach us via the email, or you can even approach your local patient advocacy organizations. Maybe they can help us a bit more information, or you can write to us, of course. What the results show, we have our technician who is going to show the results on the screen very soon. And now we got the results. We see that you actually think that there are many different concerns about regarding the treatment of ovarian cancer. And I do agree with you. It really depends on the journey, on a patient, on different parameters. And there is probably the most prominent answer we can see is recurrence. And yes, of course, there is, as with any cancer, there is a chance of recurrence. It might be a high percentage for certain types of ovarian cancer. We can discuss it with our experts in the next room that we are going to visit. We see that you're also seeing that emotional burden is a big thing. So it's very nice that we had Stephanie in the beginning of our journey that was telling about this part. I would say there is no one problem. There are multiple problems that all need to be addressed. So very nice that you're active. And I think we continue and move to the next room, which is the treatment and innovation room. Sounds very cool, right? Olivia, do you want to help me with the introduction of this room? Because I've never been to this room before, actually.
We now enter the Treatment and Innovation Department. Fiona and Sophie have both received a diagnosis of ovarian cancer, but their treatment pathways may not be identical. One will start with surgery, while the other will receive neoadjuvant therapy before surgery. This reflects real-life ovarian cancer care. Treatment must be individualized and ideally discussed by a multidisciplinary oncology team. In this room, we will hear about prehabilitation, biomarker testing, treatment planning, and patient experience.
Very much, Olivia. It was nice to hear your voice. It seems like you feel a bit better. And we are going to continue with this room, which is treatment and innovation room. And there are several experts who actually sit in this room. We start with Christina, Dr. Christina Fotopolo from the UK, who is going to talk about rehabilitation. Maybe not you are aware of this word, and preparing for treatments. So what can you do before the treatment is started? So Christina, welcome.
Thank you, Zoe. Thank you, everybody. Can you hear me all right?
Yes, we can perfectly.
Okay, perfect. So thank you so much for having me in your team today. It's a great pleasure and honor, as always, to be part of the ENAGAGE initiatives. So we're going to talk in the next few minutes about prehabilitation and preparing for treatment. These are my conflicts of interest. So what is the concept of prehabilitation? Prehabilitation is, as the word says, pre, so before, preparation. And this is a concept that has been increasingly new now in oncology. As you may remember, we had for many years the rehabilitation, which is the recovery after the operation. And this concept of getting ready before the operation, before any treatment, is now new in the last few years. As one would never go and run a marathon without being prepared, without having water, without having exercise, the same actually applies to the surgery. Surgery is nothing else than a journey. It's nothing else than a fight, really. And as much as we all would like, because as Zoe also has rightly said, we may be doctors today in this seminar, but all of us have been patients and all of us have been where you are, and we are all really on the same boat. And we all know that we all would love to just be sitting in a room and just having treatment coming to us without needing for us to fight, but that's unfortunately not the case. And we need to prepare for the journey that comes ahead of us. And many studies have shown that the higher the baseline is before this start of the treatment, the better and the less steep we can fall, because we will always fall, because any treatment is always a trauma during treatment, so that we can go up again. So, as trivial as it may sound, prehabilitation is the fitter you are, and the fitter you come and enter into an operation, the fitter you will come out of this operation. And this is not just exercise, but it's a multifactorial axis, really, of many aspects that we will go and see today. The concept of prehabilitation has started to be examined really in less than the last 10 years. There are many studies that show that this adequate preparation before surgery, before start of treatment, is associated not just with better recovery, but also with lower complications. And we see here in many, many studies that you don't really need to read all of this. The only thing you need to see is that the columns, the forest plots, are more towards the left side, is that the majority of the studies have shown that this pre-operative preparation and coaching and mentoring and exercise and nutrition is associated with better and quicker recovery and also lower complications in many, many retrospective studies, which, as you see here, have really started in the last decade. So there are no earlier studies really before 2008, 2006. Now, what we have seen is that there is a very strong association between how frail somebody is for a better recovery. So we know that we don't talk anymore about older or younger patients. We talk about frailty and non-frailty. And this frailty and non-frailty means that even younger patients can appear more fragile. And also older patients can be actually fitter than somebody who is younger. So we use the word frailty, and we use the ECOG status, which is the performance status of every patient, and various frailty index to see how fit and how ready somebody is for the fight, is to run the marathon, is to go and have a contest, is to go and have a journey. And we have seen that besides frailty scores, albumin scores, when you are being prepared in terms of a prehabilitation concept, this is actually associated with a better survival after any treatment, just because as a patient, you are then in a better position to tolerate that treatment. Now, something that we have seen as an empiric model really from 2008, 2009, we have for the first time in 2019, so that's just a few years ago, implemented in our guidelines. For the first time, the word prehabilitation has come into the ERAS guidelines, so the perioperative enhanced recovery guidelines in 2019, where for the first time we have said that prehabilitation is a new concept, is something that we should all strive for. The evidence is low and the recommendation grade is weak because in 2019 we didn't really have enough data yet. But the data that we had were enough to say that there is a value in it. So what is this concretely concept of prehabilitation? It includes physical and psychological assessment and improvements. It includes targeted intervention to improve patients' health as long as we have before the start of the treatment. We have today, as Olivia has said, 2 patients. One will start immediately the surgery and the other will start after neoadjuvant chemotherapy. It goes without saying that the patient who will have surgery after neoadjuvant chemotherapy will have a longer period of time to prepare herself for the surgery, which is one of the main advantages of neoadjuvant chemotherapy. And also going beyond the physical assessment, we also talk about mental well-being, being able to cope with stressors and to get used to the reactive process so that we can restore wellness better after the operation, which is then the so-called rehabilitation that you all know. So what does it include? It includes aerobic and resistant exercises, functional exercises, also mental exercises to prevent impairments, Very important dietary interventions in terms of high protein, low carbohydrates, low toxicity, low toxins, especially a lot of artificial food, a lot of ready-made food, a lot of carbs, a lot of, we say in Mediterranean diet is one of the best for this area. And of course, psychological interventions to reduce stress. As Zoe has said, and Olivia in the beginning, we are not just patients, but we also are mothers, our daughters, have to, at the same time with our anti-cancer treatment, also have to look after kids, our parents, do the job. So all these are cumulative factors that increase our stress. How does an exercise targeted program, for example, looks like? And I use here the example of the Charité in Berlin, which was one of the first centers that implemented these programs, is aerobic exercise 3 times per week, including relaxation exercises, including breathing exercises to improve lung capacity. So, for example, any chest infections, any pleural effusion after the operation can be tolerated better. Food, yeah. If somebody is weak, has low albumin, that we increase their albumin and their protein contents with protein drinks, with carbo loading, with improved diet programs. And of course, mental health and empowerment with coaching, with relaxation techniques, with a group and patient support groups. All this has and should start before the start of the treatment and not after. Now, in the last few minutes of my talk, I would like to present to you the first really prospective randomized trial of prehabilitation in advanced ovarian cancer. This is the core innovation. It's a study that really examined prehabilitation, yes versus no, in surgery for advanced ovarian cancer. It was presented by the team of Jalil Zehouli, our ESGO president, in ESGO in Copenhagen this year. It was 414 patients. And what they did is they had a very comprehensive frailty assessment, 3-modal rehabilitation, physical, psychological, and nutritional, and implemented supportive strategies in one arm. And they just did the standard arm in the other one. You see here how multimodal everything was, with walking, with nutritional scores, with mental support. So it was a very complex, it was a very, very complex study that got really a massive funding also from actually the German government. So what these results interestingly showed was that the severe complications were not different between the 2 arms. They were relatively high because it was very advanced surgery, so they were not different. However, what was different was that in patients who had the prehabilitation, they had shorter stay in intensive care unit, they had shorter stay in the hospital, they had shorter readmissions, so necessity because of emergencies to go back to intensive care unit. And also they were fitter and better and shorter time to start chemotherapy after the completion of surgery. So very significant factors that also could be measured in black and white measurements, like, for example, faster mobility, improved walking capacity, great muscle strength, and also overall better balance, less falls in the prehabilitation arm. So even though the prehabilitation arm failed to have lower complications, the overall recovery was much better, the overall mobility was much better, and also the going back to normal was much faster. So the findings of this very important study that is now going to be admitted in Lancet, one of the largest and most important journals in medicine, is lower quicker recovery, better efficiency, higher stability for our patients. And of course, this will bring the prehabilitation in a much more objective and evidence-based method in our institution. So till then, some very small last practical facts. Assess time to surgery. We have today 2 patients, primary versus interval cytoreductive surgery. See the time you have. For example, it's impossible to do prehabilitation when you do the surgery next week. Yeah, it's almost impossible. But use the time if the surgery is delayed, because for whichever reason the patients cannot be operated first. correct anemia, iron versus iron infusions versus transfusion, protein drinks, maintain physical activity, psychological support, social support, very important. We can't leave our patients alone. They need help for their family, for their children, for their parents, for their work. And coaching and mentoring. It's not anymore to operate well. It's not anymore to be a good chemotherapy doctor, but to have the network for a holistic care for our patients. Thank you.
Now we got an overview on what is it, rehabilitation, and how should we prepare for the treatment. And we can give this advice to Fiona and Sophie. But we have a few more insight from our experts, and we continue with Roman Kochan from the Czech Republic, who's going to talk about biomarker testing and why it matters. Please.
Good afternoon. Thank you, Zoya. I feel honored. It's my pleasure to be on the June Rota list with you in this virtual hospital. And I will speak about biomarker testing in ovarian cancer and why it matters. We should start with the simple question, what is biomarker? And we can say that it's a measurable signal coming from the tumor, and it can be found in the tissue, DNA, or in the blood. And it helps us to choose the most appropriate treatment, and biomarkers help make treatment more personalized. A tumor is more than a cancer cell. A tumor lives in a complex environment with immune cells, blood vessels, supportive cells, and many signaling molecules which interact with each other, and some help the body fight the tumor while others help the tumor survive. So this image on the left reminds us how complex tumor tissue is. This is the picture of ovarian cancer, and it is not just one uniform mass, it's a living ecosystem. The blue dots are cell nuclei. The green signal shows one biological component of the tumor tissue. The exact marker is not the main point here. The key point is that ovarian cancer tissue is biologically complex, and understanding this complexity can help us develop and choose better treatment options. So same diagnosis, different biology. Two patients may have the same cancer type and stage of the disease, but their tumors can, should, and might behave differently. Why? Because the tumor biology is different. The tumor may look similar under the microscope, but biomarker testing can reveal important differences. And these differences are not always visible by routine pathology alone. As you can see on the left picture, this is the ovarian cancer under the microscope and the basic staining. And we can find differences if we use a different kind of staining, like immunohistochemistry. And in ovarian cancer, this is especially important because treatment decisions depend on tumor biology. And precision medicine starts with tissue. So we do core needle biopsies, and a small tissue sample can reveal important biological information. And what we do ultrasound-guided core needle biopsy, and it is low risk, fully outpatient, and mainly well-tolerated procedure. And results from these tiny tissue blocks are available within 1-2 weeks, and then we can decide what is the best treatment for the patients. And we will receive a tumor morphology and also important results from molecular testing, like we call it ENAGAGE with the sequencing. This is how the procedure looks like. We usually put the tiny needle on the top of the vaginal ultrasound probe. The procedure is done transvaginally or transabdominally. We obtain at least 2 tiny 1 centimeter long, few millimeters thick tissue blocks, and then we send it for the special examination. And I will show you a short ultrasound clip. This is the video showing you the ultrasound of the pelvis. You can see the rounded, we call it like a multilocular solid ovarian tumor on the right side in a yellow circle. And then you will see the bright white line entering the tumor and performing the biopsy. And it will enter the tumor in a few seconds from the bottom of the picture. Like now, you can see the bright white line, and it will shoot and it will take a tissue sample out of the tumor now. So this is how we do the core needle biopsy, and in this case, it's done transvaginally. And I will speak about two biomarkers in ovarian cancer. And the first one is when DNA repair is broken. So DNA in healthy and cancer cells is damaged all the time. And cells have repair systems that fix this damage. And one important repair system works like a zipper. And when it works, the zipper closes and DNA is repaired. But cancer cells can have weaknesses. And one of the weakness is that in some ovarian cancer, this repair system, the zipper is faulty, is broken, and the cell cannot repair DNA damage. And we call it HRD, homologous recombination deficiency. And the treatment which use this weakness is oral maintenance treatment, which comes after the response to platinum-based chemotherapy. And this treatment is called PARP inhibitors. And they increase DNA damage in cancer cells. And if the HR deficiency repair system is broken, the cancer cells cannot survive. And we speak about synthetic lethality mechanism on PARP. And you can see in this scheme how it works in a normal cells. When PARP recognize damage and it repair it, and DNA is repaired. And when the patient is treated with PARP inhibitor, it blocks repair. There are more severe DNA damages. The normal cells still can have some backup repair, which works, and DNA is again repaired. But in patients with HR deficiency, for example, with somatic or germline BRCA mutations, this backup repair does not work, and the cancer cell die. This was about the HRD is one example of biomarker inside the tumor cell, and now I will speak about another one, and this is the target on the tumor surface. So some cancer cells carry a specific address label, for example, folate receptor alpha, and we use this target if it is present in ovarian cancer to use a very effective treatment, which is called antibody-drug conjugate. And you can see this antibody-drug conjugate on the picture, ADC. This is the antibody, the Y-shaped antibody, attached with a cytotoxic drug by a glue, which is just a simple, usually peptide linker. And how it works, we can show you that it works like it was in the past with the Trojan horse story, that the antibody is the Trojan horse, and folate receptor alpha on the cancer cell is like a tumor gatekeeper. And these hidden barriers in the Trojan horse is the cytotoxic drug payload. So basically, first, the antibody finds the target on the ovarian cancer cell. It binds to a surface antigen. After binding to the target, the treatment enters the cancer cell. And once inside the cell, the drug, the payload, the Greek barriers like Odysseus or Diomedes, they are released and it damages the cancer cell, and then the cancer cell then dies. So the principle of ADC is simple: find the target, enter the cell, release the drug, and kill the cancer cell. So this was the story about two biomarkers, two treatment strategies, about the homologous recombinations deficiency, which uses DNA repair weakness, and in this case we use PARP inhibitors, and another, especially for recurrent ovarian cancer, we can find out if these cells express folate receptor alpha or other receptors on the surface of the cancer cell, and use very effective new drugs, which we call antibody drug conjugates. Precision medicine begins with diagnostics. The same cancer diagnosis does not always mean the same disease. Tumors may look similar, but their biology can be very different, and so can their treatment. So why biomarker testing matters? Biomarkers help us to choose treatments more likely to work, avoid treatment unlikely to help, and especially reduce unnecessary toxicity. And access to biomarker testing means access to personalized care. We test the tumor, find its weaknesses or target, and choose the right treatment. So thank you for your attention, and once more, thank you for the opportunity.
Thank you very much, Rowan. It was a beautiful talk. And now our colleague Els from Belgium is going to continue this discussion about individualized treatment decisions. So Els, welcome on stage. We are happy to have you here today.
Thank you for the introduction. Let me just share my slides. And as we've experienced some troubles in this virtual hospital, I've experienced some troubles with my own institution. So I'm not able to get my slides I prepared for this presentation. So bear with me with some Dutch words on this one, but I'll verbalize it all in English. As I've seen from the polling that a lot of you have, of course, concerns about the risk of recurrence, and we've seen the curves that Jürgen has showed that we have a 5-year survival rate below or around 30%, but we also are pushing up these bars and getting to better survival rates for our patients. So what have we done in the latest decades to improve the therapy for an advanced ovarian cancer patient? And actually, in the past, it was very poor. We only had our platinum-based chemotherapy, Taxol, carboplatin, that what we are giving for around 5 months' time, and then it stopped. And then how the last presentation showed you that, and very love the zipper approach, that there are some differences between the ovarian cancer tumors, and we have learned a lot in 2011, which was really a turning point where we got to know more about the genetics of these tumors, what is really driving these tumors, and that has given us a chance to actually exploit their advantages as a vulnerability as well to attack these tumors. So this is the same principle as Roman just showed you, that a lot of these ovarian cancer, and we're talking about the most frequent ovarian cancer subtype right now, the high-grade serous and high-grade endometrioid subtypes, are driven with mistakes in their repair mechanism. And that's about 50% of these tumors. So that gives us a good chance of exploiting that as an option to treat these patients. So most of them have mutations then in the BRCA1 or BRCA2 genes, but there are all different sort of genes involved in these repair mechanisms. It does not only rely on the BRCA genes. Bear in mind, I've talked about this is the most frequent subtype, high-grade serous, high-grade endometrioid, which is about 70-75% of our epithelial tumors, but there are many different histologies. Most of them are then, of course, rare histologies. There's also a patient behind this diagnosis. And we have looked in these other subtypes as well, these more rare subtypes, and there are many potential biomarkers. No, they look different in the microscope, but they also have different genetics driving them as a tumor. Although we've examined that quite extensively at this time point, most of these biomarkers have been prognostic, and very few serve as a predictive biomarker or a biomarker we can choose to target with new new treatment options. So where did we really have the first most important change, and what we have implemented today at the time of diagnosis when the patients come with a stage 3 or stage 4 disease and either go into neoadjuvant chemotherapy and then an interval debulking or primary debulking surgery followed with adjuvant chemotherapy, or some of them might not be operable in the first line and only have the chemotherapy. What we really need to do at time of diagnosis for our patients is to assess the BRCA status and the HRD status. We really need to know whether in this ovarian cancer patient these repair mechanisms are broken, because we have drugs to target them. And these are the PARP inhibitors, and we have a lot of PARP inhibitors that have been tested. In many countries, there's even more than one PARP inhibitor on the market. And it started with the BRCA mutated patients, the patients that have mutations in BRCA1 and 2 genes, where we have tested the use of these PARP inhibitors. And we have done that compared to giving them nothing, like it was in the past, just giving their adjuvant chemotherapy and then nothing, or the adjuvant chemotherapy and then followed by the PARP inhibitor. And for the BRCA mutated patients, that really made a tremendous difference. You can see the curves as a blue line for the patients that received the PARP inhibitor, and the red line for the ones that did not. So we improving the chance of not recurring, improving the chance of staying longer alive. This has been tested in several trials, so we are really certain about the effect of a PARP inhibitor in this setting. But like the pie chart earlier on showed, it's not only patients with mutations in the BRCA1 and 2 genes, there are other genes involved, and also those tumors may rely very hard on the homologous repair deficiency to really divide further on, metastasize, and recur. And also in this population, we have demonstrated that the use of a PARP inhibitor or a PARP inhibitor with bevacizumab, which is a drug that targets the development of new blood vessels. If a tumor grows, I always tell patients, if a tumor grows, it also needs its oxygen and nutrients, so it needs new blood vessels to be able to grow. We have proteins in our body to actually build these new vessels, and bevacizumab is one of the drugs that actually can block the tumor of making new vessels. So there is a synergy probably between olaparib and bevacizumab, which we can use in these homologous recombination deficient patients that also benefit of the use of a PARP inhibitor at time of diagnosis, so following their platinum-based chemotherapy and giving it as a maintenance drug to these patients. So demonstrated in more than one trial, the POLA-1 trial, in the combination, the PRIMA trial that looked at only niraparib, one of the PARP inhibitors, as a maintenance, unfortunately, did not show any survival benefit. But what about the HRD negative patients? Is also 50% of the pie chart, of course. What do we give? What do we give them? And also, HRD is a difficult biomarker to assess. It's probably more a continuous biomarker. It's not that we test that tumor in the lab and it just goes 0 or 1. It is a score that we get, and different tests use different scoring mechanisms. And maybe if you're not just under the score of the HRD positivity, then maybe you would benefit for a PARP inhibitor or not. So it's a biomarker we have besides BRCA mutations, but it's not the most ideal biomarker, since it's a more continuous biomarker. So what else is there? And certainly for that population that is HRD negative, so homologous recombination deficiency negative, there are other mechanisms probably driving these ovarian cancers. So what else is there to use? And there is a very vast and very fast developing segment within oncology, whole of oncology, and that is the world of the ADCs, the antibody drug conjugates that are rapidly evolving. The ADCs, as Roman just showed you, is a mechanism where we have a molecule where we put a little bit of chemo onto to it. If the chemo would be given by an infusion just by itself, it's in that very low dose, it won't do anything. But it's just a very small dose that's linked onto that molecule. And what that molecule does is actually looking for the slot, the key to enter the tumor cell. So it needs to bind to the tumor cell before it gets internalized by the tumor, and then it releases the chemotherapy and kills the tumor cells. So it's really a bit of a way of delivering smart chemotherapy, bit more directed chemotherapy, more directed towards your tumor cells. And luckily, because cells need to be able to communicate with each other, that's the way we can actually live as human beings. All our cells need to be able to communicate, and we have like little antennas, little molecules or proteins on the top of all our cell surfaces to be able to communicate with each other, like we need to make a phone call, and we need antennas as well. So there are a lot of possible proteins, antennas we can use to actually direct this kind of molecules to cancer cells. And this is just, and it's already outdated because this is an example from January 2024. These are all ADCs in development, and each color is another drug directed to other biomarkers. So there's a vast magnitude of ADCs that are being developed, and also in the gynae space, and also certainly in the ovarian cancer space. The one that we first got to know and is approved by the drug agencies in the United States and in Europe is mirvetuximab, which was already also alluded to, which is directed to an alpha folate receptors, one of the many antennas we had. We've done that study with mirvetuximab years ago, which was negative because we used it on all ovarian cancer patients. And then we really looked into, now, do we need just a little bit of the expression of the alpha folate receptor, or do we need a lot? Because that's also a different difficulty with these biomarkers. For some, it's okay if you have like one antenna on top of the cell surface. For others, it matters how many antennas you have, and you need a bit more intensity of these biomarkers for the drug to be able to work. And this was the case with mirvetuximab. So if you look at the patients that have a high expression, there the drug really makes a difference compared to normal standard chemotherapy. And this might be the reason that when we now speak to patients, when they recur, and we think, okay, we need to test some other biomarkers, your doctor maybe speak about alpha folate receptor or some other biomarkers, that for some, it really matters how much you have. It's not all just going to be alpha folate positive, but we need sometimes the intensity of the positivity as well before you can get a drug, before you can enter maybe a specific trial that works with a biomarker. And some of them, the best biomarkers you can have is just, it's okay that there's like one antenna and the drug can work, and we do not need to screen our patients for these biomarkers. And that is a bit more the holy grail that we are working to in our clinical trials that are ongoing for the moment. So mirvetuximab for that drug, really the cutoff of the staining matters. And this is how it looks when the pathology looks to the tumor cells and looks for that expression color of the alpha folate receptor biomarker, which is with the lightest brown low, and in the dark brown it's a high, and it's in the high expresses that this drug works. Where else can we go? And also for the EDCs now, the mirvetuximab, just to go back, that has been tested in the recurrent setting. ADCs for the moment are going up in clinical trials, and we are testing them also, for example, for our HRD negative population at time of diagnosis, to use these drugs as a maintenance strategy after the platinum-based chemotherapy. So certainly for the group of patients where we do not have PARP inhibitors at time of diagnosis, the clinical trials are underway to use ADCs as a maintenance in that very first line, very first treatment of advanced ovarian cancer. So what else is there? What else can we attack from this tumor? Because ADCs, it's a new field, it's a new development. It's still a bit of chemo that we direct to the cancer cell. Well, the cancer cell is not just an island on itself. It exists within the body, and normally our immune system should attack that strange cell that's not doing anymore what we normally expect from a normal cell. It should detect that there is a strange malignant cell in our body. But a cancer cell, and certainly ovarian cancer, is quite smart to keep that immune system far away, to block it, to be able, making it unable to attack the cancer cell and kill it. But of course, we are doing the trials, have done in the past, and are continuing to try to redirect that immune system back to the cancer cells. You have sometimes heard in the media that we have made tremendous progress in some cancers with immunotherapy, like in melanoma and lung. And I always say these are the simple tumors. They are very hot. When you take one blockage away for the immune system, it will be able to attack the tumor. But ovarian cancer throws up a lot of blocks, so the immune system is having a very hard time to invade again and to attack the tumor again. So it's really a case of how can we turn these cold tumors, these desert tumors, hot again? How can we let the immune system infiltrate the tumor cells again? And there we are making progress as well. And this is one of the drugs that are in development. This is a molecule that will bind again to this. It's a quite similar technique in a way that it needs to bind to a protein, an antenna on to the cancer cell. And in this case, it is the protein that actually makes our CA125, which is MUC16. And on the other hand, it binds to one of the proteins on our immune cells, and it actually pulls your immune cells to your cancer cells and says, now this one you need to kill. This is not chemotherapy. This is totally something different, a different step in the field of immunotherapy, with besides the first few weeks, little side effects for our cancer patients. And this is just some activity, some first data we had from this clinical trial, that patients actually were very heavily pretreated. I've had a ovarian cancer patient that had 7 prior lines, that had this drug for 3 years onwards. So 7th line platinum resistant patient. So if you respond, you have very long, durable responses. So it's certainly a drug worthwhile further investigating in this setting. But it's not the only thing that we are doing. We have the ADCs, and there are many ADCs in development. We have novel immunotherapy agents, but we also have directed towards the cell cycle repair. So if a cell needs to divide, we all have these guards that check whether a cell can further divide, if everything is okay. And of course, a tumor has some mechanism in that pathway that they might use, disregard the guard that says you're not okay to go further into cell cycle division, and just get this uncontrolled cell division. So we have a lot of drugs in that setting as well coming into clinical trials. A small word that they are not all high-grade, serious high-grade endometrial ovarian cancer patients. We have some rarer diseases within ovarian cancer, like the low-grade serous ovarian cancer. It's totally different. It has nothing to do with BRCA mutations, nor with that HRD status. So if you are a low-grade serous ovarian cancer patient, testing BRCA, testing HRD does not matter. You need to be tested for a different pathway in your tumor. And also for this, we're making progress because we have done several trials with MEK inhibitors, again directed to the same vulnerability, the same mechanisms that the tumor uses to uncontrollably grow. We attack with our medication. And we have made progress into the MEK inhibitors recently as well. The older MEK inhibitors had response rates around 15 to 26%, but we have even improved that one recently with a different combination of a new MEK inhibitor with a second inhibitor of that same pathway. So we're attacking that pathway in different ways. Achieving actually for these patients response rates of 44% for the patients that actually have a mutation in that pathway, with duration of responses around 30 months and increasing, so more than 2.5 years on that same drug. So even for rare ovarian cancer patients, there is some light on the horizon that we have dedicated clinical trials dedicated to their disease and making progress based on the tumor biology that we learn more and more of each day. So I think there's more and more to come, and this presentation will get larger and larger and more difficult to explain in the near future. And with that, I would like to thank you for your attention.
Thank you so much, Els. It was such a comprehensive talk, and I'm sure we'll get a lot of questions on that. I just want to say to all participants that we decided to collect the questions, so you do have an opportunity to ask us, and then we circulate them between our speakers and publish the answers along with a recording of this of our virtual onco unit on YouTube. So stay aware. But we do connect her with our next, we can say colleague, Kata Koblash. She's an active member of ENAGAGE, and she's going to share her patient experience with the treatment process. So welcome, Kata. It's very much appreciated that you are ready to share your story or your feelings with us on that.
Hello, everyone. Can you hear me and see me?
Yes, we can.
Oh, okay, I can see you. My name is Kata, and I'm from Hungary. I'm an ovarian cancer survivor since 6 years now. And I was lucky to have all 3 therapies, so chemotherapy, immunotherapy, and PARP inhibitor. And I would like to tell you about my experiences with the chemotherapy, because this was the hardest thing in my ovarian cancer journey. This word is burned into my memory, because the first time I went to see my doctor, and he reviewed all my findings, and he told me that yes, I can do the operation. It was a first-line operation, a big cytoreductive surgery, and after that, probably you will be getting chemotherapy. And I think this was the moment when I realized that my illness is true. Before the first treatment, I went to see my oncologist. She was a woman, and she told me about everything, but I couldn't ask anything. I thought I knew everything, what was going to happen, but I didn't know anything. I was very afraid. I was afraid of the needle. I was afraid of the nausea, the vulnerability, the baldness. I was afraid that the chemo will never end, and that there might be unexpected side effects. On the first treatment, the nurses were very, very nice. I was sitting in a long chair-like bed. I could sleep, I could sit, I could read or listen to music. I could eat, I could drink, I could do almost everything. It lasts about 5 or 6 hours. And when I didn't feel anything wrong. And when I went home, I thought, oh, easy peasy, I will do this. It's nothing. And that night I got very, very sick. I had a terrible nausea, and I couldn't vomit, and I was feeling myself very ill. After this night, 3 days, I only slept. I couldn't get out of the bed. But after a few days, I got better, and a week later, I was fine. Then after 2 weeks, my hair started to fall out. I knew that this moment would come, but I wasn't prepared. That was the hardest moment of my therapy. I felt like I've lost the last pieces of my femininity. A huge scare on my belly, my body was deformed, and I had lost my hair, so I was very, 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 very sad. I thought that I looked like a real cancer patient, and I was indeed. I didn't buy a wig. I used scarves, and my daughter filled my eyebrows. I put on lipstick. I painted my nails red, and slowly I started to feel myself again as a woman. My family, my partner, my children, my friends helped me a lot. I had a messenger group named the Guardian Angels. This was a group of my closest girlfriends who gave me a very, very big support. They loved me just the way I was. And as time went by, I felt that it was more easier, and finally the last day comes. And I decided that I want to help other patients, other women who were in the same situation that I was, because the doctor cannot tell everything. They probably don't have as much time, and they don't think about practical things which you can face during the chemotherapy. I think that I would tell to myself, to my former myself 6 years ago, that don't be afraid to cry, don't be afraid of being second line, because you are not, just because you are ill. Everything that hurts, everything pain, everything that you are afraid of will pass, and you will be stronger after fighting this battle. Thank you very much for your attention.
Thank you very much, Kata, for sharing your story. Yeah, we shouldn't forget that there are a lot of feelings behind and emotions behind every story. Therefore, we do proceed to the next room that we call, at our hospital, we call it patient and family support. Olivia, do you want to help me to explain what that place about?
We now leave the treatment department and enter the patient and family support hub. Ovarian cancer care is not only about scans, surgery, and medicines. It is also about fear, relationships, work, family life, intimacy, uncertainty, and hope. In this room, we will focus on the emotional and social side of care.
Yeah, in this room, we will listen to a patient perspective. We have 3 amazing patients, and I can even call them patient advocates. And we start with Alžběta from the Czech Republic, who's going to talk about emotional and psychological impact of cancer treatment.
Hi.
Nice to see you again.
Hi, my name is Bette and I have ovarian cancer, and I would like to talk to you about emotional and psychological impact of the cancer treatment. One of my biggest struggles was losing my hair when I started chemotherapy. My doctor told me to cut them before I start losing them, because it wouldn't hurt as much when you're losing a really long hair. I had hair like here or so long, and it started when I was in the hospital. I just touched my hair and the hair were everywhere. We were at the doctor's for some checkups and so on. And when I came home, I decided I want them gone. I just don't want to look at my hands and see so many hair falling out. So I shaved my head. Not me, I tried, but my mom shaved my head. And when I looked at the mirror and saw myself for the first time without hair, I was feeling so ugly, so ugly. Afterwards, I started to wear outside these scarves, and I have, in my experience, people didn't notice that much. I don't have a hair, but when my eyelashes started to fall out and my eyebrows, it started to be noticeable. People were sorry for me. People were sad when they look at me, and I was sad too, because I felt how when I go out that everybody is sad because of me. Now I'm undergoing a hormonal treatment and a biological treatment, and I have my hair back, and right now I notice a big change. People feel like I'm healthy. They go to me and say, "Oh, you look so healthy," and so on. But I'm not. I'm still struggling. I'm still struggling as when I had my chemotherapy. The side effects are not as bad, but they are still pretty bad. You know, the bone aches and the tiredness and so on, and people don't see it. I struggle at home and people don't see that part, and they feel like everything is fine. So that's really hard for me, because when I were undergoing the chemotherapy, strangers just came by and were really kind and helped me and so on. But right now everybody just thinks, oh, a healthy girl. But that's not true. In the end, I would like to say that fighting cancer isn't hard only because of the side effect of the treatment, but also because of the fight we have inside our head, fight with our traumas, fight with our flashbacks to the time we were worse, feeling worse, and so on. So I would like to say, don't give up and let's fight her.
Thank you so much, Alberta, for such inspirational talk. Thank you very much. It means a lot to us to hear your story. We want to continue with Caroline from the All Life. It's an organization in the Netherlands. So, Caroline?
Yes, thank you very much for the introduction and for the invitation to take part. First of all, I'll tell very shortly about my health. I'm 66 years old now, and when I was 47, so next year that'll be 20 years ago, I was diagnosed with ovarian cancer, stage 3C. I have a BRCA1 mutation, and I've had 2 recurrences since the initial diagnosis. And I was in 2015, I had my last chemotherapy sessions, and I was very lucky that from the trials, the PARP inhibitor olaparib was released to be made available for patients. So when there was not full remission after the chemotherapy, I was allowed to take the olaparib, and it works really well for me. I have hardly any side effects, and I can take the optimum dosage, etc. So I'm very lucky to still be here after 20 years after the first diagnosis. That's really saved my life. One of the earlier speakers was talking about social support and communication, the importance in the contact between doctors and patients. But in relation to your caregivers, your family that surround you, that's also very important. All of a sudden, when you're taking ill with cancer and you have a big operation, you get chemotherapy, and when you get recurrences, the chemotherapy sessions again, you're a patient all of a sudden, and you find out that you're really very ill and you can't do things on your own again. I'm very self-sufficient always. If I'm in the kitchen after dinner dealing with the pots and pans, my husband will call from the room saying, "Can I help?" I said, no, I'm fine, I'll do it myself. I never asked for help. But when I was really ill, I had to have help. So that felt like a burden to me, that I had to ask my husband and my daughter to help me. Somebody pointed out to me, remember that it's also nice to take care of somebody who needs help. And when she said it, I realized it's true. I like to help somebody who is in need of help. So I shouldn't stop. I realized I shouldn't feel guilty about the fact that I needed to be helped, even though it felt strange because I never asked for help. The fact that I needed help made me feel guilty. There are other things that made me guilty in relation to my relatives, my caregivers. Of course, it's difficult for your family to realize that you're so seriously ill all of a sudden. When you get a recurrence, you feel guilty about that you have to go through the chemotherapy again. The difficult times are coming again. And when I found out I got a genetic mutation, I felt guilty towards my daughter. I have one daughter, and I was really scared that she might have inherited as well. I had to tell her that there might be a chance that she inherited it as well. So it's guilt upon guilt feeling all the time. One of the other colleagues at Olijf told me that she had to inform her family about the fact that she had a genetic mutation, because other people in her family ran the risk also of being a carrier of this mutation. And she said some people really got angry with me because I burdened them with this information of having to be tested, etc. And I think that's also the reaction that you get from relatives with regards to a genetic mutation is also related to personalities, of course, how people react, and family dynamics probably. I mean, we have Scandinavian genes and we're quite basic about things, and we'll see what happens. So my daughter wasn't very stressed about it at first. She got tested 10 years later, and it turned out that she didn't inherit it, fortunately. She's got 2 beautiful children now without IVF, etc. But that can be really difficult. I also found it very difficult to share with my family how worried I was, how scared I was about whether the treatments were going to go well and whether I would survive the treatments. I didn't want to burden them because they had their own worries and their own sadness and grief about the whole situation. So I found a psychologist who specializes in helping people with cancer, and that's something I can really advise patients, because over there I could cry and I could talk about all my fears and my worries without burdening my family with it, who are also dealing with their own process. I think that doctors should offer this opportunity or suggest this thing that you could talk to a psychologist who can help you with the whole process of having cancer. That should be done. I mean, I've had 2 oncologists in the past 20 years, and nobody has ever said, would you need any psychological help or something? Another thing I'm going to finish with that is that there might be estrangements with your friends or family even, because people don't understand what you're going through. They're scared of cancer. They are scared of the disease. They're scared of the fact that you might die. You might lose friends who don't want to be in contact with you anymore, and that's really difficult. People can also react very strangely. Another colleague from our life told me that she has ovarian cancer stage 4, which had a very poor prognosis. And well, after a year, when she was walking through a village, somebody came up to her and said, are you still alive? You were supposed to die. It's really, people can react really strange to the situation when you're ill. Another young woman told me that she had cervical cancer, and when somebody wanted to visit her on a Wednesday afternoon, she said, well, that's not very convenient. My children are at home Wednesday afternoon. But this lady interpreted what she said like she needs space. So she didn't contact her for months. And afterwards, she heard that she had interpreted her remark like that. So there might be, she had a practical reason why she didn't want to meet that particular Wednesday afternoon. But this lady didn't talk to her for a long time, and after a long time it became very difficult to contact her because you don't know how somebody's doing or something. So I think we have to, as women, we have to get rid of our guilt about the situation that we're in towards our family and our caregivers, because we can't help what has happened, and people that love you in general will be very happy to help you. And I think communication has to be very important in the whole road that we have to go with cancer. Thank you very much.
Thank you very much for the story, Caroline. It's very insightful, and it's very brave that you share your story with us. Thank you very much. The next patient that is going to share her story is Birte. Birte is from Denmark. So Birte, we are really looking forward to hear your story.
My name is Birte Limley, and I have lived with ovarian cancer for a very long time. Actually for 18 years, and then it stopped. Or maybe not, you never know. But I've been cancer-free for 7 years now. At the beginning, I will elaborate a bit on the symptoms. It started with a swollen stomach. I went to the beach with my daughter and she said, "Mommy, why does your stomach look like that?" I didn't know why, but of course went to my local practitioner. She had no idea either. They took a blood test, which was normal for what they were looking for, so I was told that there was nothing wrong with me. I noticed the following, though. I was a teacher and suddenly needed to use the bathroom to pee between lessons all the time, but not very much came out. That was very unusual. But the teachers at the college where I was working were all going to New York. I was an English teacher and was, of course, expected to go with them. My daughter went with me to the airport, and I said to her, maybe I shouldn't go. I don't feel well at all. And she just said, "You will regret it if you don't go." On the trip, I felt ill most of the time, and my stomach was bloated. When we came home, I went back to the local practitioner, and this time more thoroughly, and sent me off to a gynecologist. From then on, things progressed. But unfortunately, I was already in stage 3C, where this cancer is very hard to cure. I had chemotherapy, but for 2.5 years, and I went back to work. But then the intervals between treatment started growing shorter, and I was ill when the students had to pass their exams. I then gave up the job and the teaching job. Later on, I became co-chair in 2017 and chair of the patient organization called KIU, an organization in Denmark. By chance, I listened to a professor who had been to the Mayo Clinic in the US and had seen how they did surgery there. I contacted him afterwards and asked him to do an operation on me. He asked for my patient records, which I sent to him. The answer was no. He couldn't do that. Then I organized an appointment to the hospital where he was working and brought my husband and my daughter with me. I succeeded in persuading him to do the operation. It went well, and I was again well for another 2.5 years. Then I had another relapse and another operation by a female gynecologist this time. I got an anastomosis on my small intestine. I was well for 5 years. The gynecologist was very angry with me because I did not want the chemo treatment afterwards, which of course I should have accepted. So I have no BRCA mutation and no HID. I'm what is called HRP. This means that olaparib and niraparib do not work on my type of ovarian cancer. By the way, there's now one more parib in the Danish market, and that is rucaparib. Anyway, after the 5 years, the relapses started up again. I wanted surgery and had surgery in 2016 and 2018. When it came back in 2019, my oncologist, which was put a gynecologist and a liver surgeon on the job. That was in 2019. I've had no relapses since then. How are things today? There are new treatment options like ADCs, which are not only being used for ovarian cancer, but also for endometrial cancer and cervical cancer. We are all hoping that they might lead to a cure. ENAGAGE, an ADC, was approved for treatment in Denmark by the Danish Medicine Council, but then the price negotiations started, so ENAGAGE is still not on the Danish market for the patients. In Germany, new medicine is available to the patients as soon as EMA, European Medicines Agency, has approved the drug. This is not the case in Denmark. Worst case scenario is 2 years, but ovarian cancer patients cannot wait for a drug for 2 years. So what do we need to do in connection with the disease? In stage 1, it can be cured. In stage 2, the chances are good. But most women are diagnosed in late stages and end up dying from the disease after many treatments. CA-125, which is the blood test that is measured, can be falsely positive and falsely negative. Mine was elevated after surgery, which of course was not due to ovarian cancer. We have to find a new way of diagnosing this disease earlier. Maybe it can be measured in the blood somehow. Maybe the new ADCs are a solution, time will tell. But we still have the issue with diagnosing it. They use CA-125 when I was diagnosed many years ago, and they're still using CA-125 in 2026. Diagnosing ovarian cancer earlier, maybe by a blood test, could save lives. Worldwide, there are 324,000 ovarian cancer patients per year. About 200,000 women die of ovarian cancer every year. They wouldn't die from the disease if they were diagnosed earlier. So that should be our goal for the future. Thank you for listening.
Thank you very much for insight, Birte. Stephanie, may I ask you to summarize?
Sure, I would like to thank all the lovely ladies for sharing their inspirational stories. And I think what we have heard today reminds us of something extremely important, that cancer care is never only medical. Behind every treatment pathway, every scan, every clinical decision, there is also the psychological experience, a person, a family system. And that experience often includes intense emotions such as fear, uncertainty, guilt, as it was mentioned earlier, grief, identity changes, body image changes, relationship challenges, isolation, and the ongoing effort to maintain hope while living with unpredictability. And I think what has been especially powerful in testimonies we heard today is that they highlight not only the physical burden, but also the emotional labor of living through it. And in psycho-oncology, we often say that cancer affects the whole person, not just the body, but their sense of self, their sense of safety, their thoughts about the future, their relationships, and their meaning they have. And this emotional impact does not happen only at diagnosis, it evolves continuously across the cancer journey. And for some patients, distress starts at different time points. And what is important is recognizing that psychological distress is a deeply human response to uncertainty and disruption. And at the same time, we see people demonstrating extraordinary resilience, not because they are not afraid, but because they continue to adapt, to cope, to hope, and to move forward despite their fears. And this is why psychosocial care is not a luxury component in oncology care. It is part of quality cancer care itself, not just for patients, but for their families too. And importantly, patients often remember not only the treatments they received, but how they were emotionally treated throughout the process. If they were feeling listened to, if they felt respected, if they felt informed, if they felt emotionally accompanied. And these experiences matter profoundly. So I think today's discussion reminds us that people do not move through cancer alone. Families move through it, caregivers move through it, us healthcare professionals move through it. And this is why compassionate multidisciplinary care matters the most, because even when we cannot remove uncertainty as a human experience or suffering completely, we can still reduce isolation, we can create emotional safety, and we can ensure that patients feel seen not only as cases or as diagnoses, but as human beings. And perhaps that is one of the most important forms of care we can offer.
Thank you very much, Stephanie. Very comprehensive overview.
Thank you.
Yeah, I think many of you forgot, but we're still at the hospital. The hospital is going to close very soon. It's already late, and we have one room to visit. So we are going to be super fast there. And as it happens in reality, we often underestimate the quality of life. Besides of that, we are going to continue to the next room. And that's our final room, as I told you. It's supportive care and rehabilitation. So patients always, often and probably always wonder, what can they do? What can they change in their lifestyle and nutrition? Maybe they can eat something special or do something special. They can run a marathon. Will it help? So there are a lot of questions around it, how to help with symptoms management and so on. And we are lucky to have Dr. Hussein here, directly from France, who's going to talk about rehabilitation and the role of different efforts in this way. So welcome, Hussein. It's going to be a short visit, but I'm sure it's going to be a productive one. Welcome, Sage.
Thank you very much, Zoya. Hi, everyone. And thank you very much for ENAGAGE for this invitation. I am impressed by the quality of all the presentations and all what the patients shared with us. I think that maybe you have all said what I had to say. So thank you very much for this, for the testimonies and for the presentations. I will start with, so my presentation today is about the patient, so the woman behind the tumor, okay? What's supportive care and rehabilitation? So this is the wall, and the idea is to look what's behind the wall. This is the wall of cancer, and we need to look beyond that. So beyond that tumor, there's the whole person with her daily life and family roles, autonomy, her body movement and her physical activity that she used to do before, the energy, etc. So there's a lot of things. And the real question is not, does the patient need rehabilitation? And it is, what does she need today to function better? So this is the right question to ask. Rehabilitation is more than just physiotherapy. It's a pathway to protect the function, autonomy, and quality of life. And keep this in mind, because there should be frequently asked questions between the patients and doctors in both ways. So this is just to say that rehabilitation can be at any moment. It can be at diagnosis, it can be before surgery, after surgery, during chemotherapy, or during follow-up, or even during recurrence. So it can start at diagnosis and continue throughout the whole care pathway. And why is that important? Because quality of life is important. Previously, we used to think that end of treatment is the finality, and we used to expect that the patient would resume a normal life after end of treatment. However, end of treatment is only the start of a new journey, where the challenges are the lasting side effects, the fear of recurrence, the uncertainty about the future, rebuilding identity, and living with disease, with that after disease. So all of these, we just heard about all of them. So I will go really fast on that, but it's really important to remember that all the time. And now with the current treatment, with what you've seen with the current treatments of ovarian cancer, survival is no longer the only endpoint. Actually, patient-centered care is the future, and the quality of lives will predict survival, adherence, and recovery to treatment. So what is the point of curing a cancer if you forget to care about the patient herself? So it's a very important aspect of comprehensive cancer care, because it has proven to improve patient outcomes, reduces morbidity, mortality, improves psychological well-being and quality of life, and even improves satisfaction. And those are many studies that confirm the same thing. So it predicts survival, adherence, and what is quality of life? Well, it's actually a puzzle of different things. There's the physical aspect of it, the social aspect, the psychological aspect, and the spiritual and existential aspect. And the social aspect, well, it is very important, and it varies by age, much more than the cancer stage. We have seen that studies have shown that there's a greater impact on family life in younger patients, and on social activities and employment, and more issues with body image and sexuality. However, in midlife, patients adapt more rapidly post-treatment compared to younger patients. And then there's always the sexual impairment that we should not forget about, and we should always talk about it. And then the social and professional reintegration difficulties. And functional social support directly influences quality of life and psychological distress. And as you've heard just before, there's an impact on even social relations with friends, with families. So it's really important to look into that and to take care of this. When we look at the spiritual and existential aspect of it, well, studies have shown also that there is an important, in recently treated survivors, there's an existential suffering and fear of recurrence. And other studies have shown that older patients report higher degrees of spiritual well-being compared to younger patients, and married patients show higher. But this means only one thing, that we need to ask all the patients, those who have their families around them or not, we need to ask them regularly if they feel good or no, if they feel like they need to be assisted or not, if they need counseling or not. And when you look at this study in long-term survivors, okay, there's nearly 90% who report ongoing supportive care needs. So very important, always ask the patient if she needs social or psychological counseling on regular basis. And even if she doesn't say it, do not wait for her to ask. You can regularly ask for it. And if she doesn't need it, then she does not need it. And then the next time you could just drop a question as well. But so is quality of life something that can be measured or no? Yes, it can be measured. there's a lot of tools to measure it. And with different questionnaires, depending on the type of cancer, and that evaluate for different domains, physical well-being, social and family, emotional and functional, with short recall periods of 7 days. This way the patient can remember what happened. So I will focus mostly on two aspects, the fatigue, because this is the invisible toxicity. And this is not laziness and it's not weakness. It's really important to talk about the fatigue. Why? Because it's the most common and distressing symptom during and after treatment. It persists in nearly a third of the survivors for years after therapy, and it impacts quality of life much more than pain. And it affects work as well. And it's also underreported and undertreated. Only 50% discuss it with the doctor, and less than 25% receive intervention, which is very scary as when you look at the numbers. Less than 25% are actually treated for that. And watch out, even when asked, patients may be hesitant to report fatigue to healthcare providers because they might believe that fatigue is already an expected and an inevitable side effect of treatment. They fear that if they say that they are tired all the time, that you might think of them as complainers. And sometimes they think that if they say they are tired and they have chronic fatigue, they will receive suboptimal treatment, so they would not admit it. And there's also, they believe that fatigue is a sign, so it also brings continuous anxiety, because they might believe that fatigue is a sign of recurrence of a progressive disease. So all patients should be screened for fatigue regularly, and there's simple ways to do that. Like, for example, when we use this scale, this analog scale, where we ask them where they are, where they state themselves in terms of fatigue, and if it's 1 to 3, then it's mild. If it's 4 to 6, it's moderate, and if it's 7 to 10, then it's severe. And there's other instruments as well. As you can see here, there are a lot of instruments that we can use in daily practice. Some are simpler to put in place and some are more difficult. And once we see that a patient is reporting chronic fatigue or recurrent fatigue, then there's a lot of things to put in place. We can check, we can do a medical assessment to see if there's a medical reason that produces this fatigue, or is it really related only to treatment, or is it psychosocial, or is it related to the lifestyle, the nutrition, or the level of activity? So, and based on that, we can manage proactively. So with physical activity rehabilitation, with psycho-oncology and CBT, sometimes by optimizing comorbidities and meds, and sometimes by supportive measures, nutrition, sleep hygiene, integrative approaches. So there's a lot of things to put in place. And this is a list that I will not go through, but this is a list that you can come back and look at it again, where there are a lot of ways to reduce fatigue and to conserve energy. And this is a small example. So some days when we are on a good day, when we are on a good day and we have more available energy, we can do what matters and stay within our budget of energy. We should not empty our tank. So we should always keep that in mind. Instead of saying, I must do everything when I feel good, we should actually empty our energy battery. We should do things properly and preserve ourselves as well. And sometimes we have to accept that there are bad days. We have less energy, we do less, and we protect our reserves. But always move, even if it's a little bit, and do some activity snacks. So just a 2 minutes walk, stand up from a chair, stretch for like 10 minutes, walk in the corridor. So just small activities, but keep on moving. That's very important. And let's talk now about physical activity and exercise. So this is something that some start slow and go slow and adapt regularly. Okay, what's the difference between physical activity and exercise or sports? So physical activity is any form of movement that causes your body to use more energy than your normal resting status. And that can be done at home, at work, getting to and from work, and during leisure time. It can be vigorous, moderate, or light. The difference is that Adapted physical activity is customizable to accommodate individuals' abilities and their limitations and specific health conditions, and can be modified based on physical and medical needs of the patient, compared to structured exercise, where it is actually planned, repetitive, and designed to improve specific aspects of fitness. Sometimes small things are important, just light activity like walking or playing ball with the kids or gardening or doing yoga or Tai Chi. So this is light activity, and it's really important to start with that before increasing bit by bit. And then you can see some more moderate or more harder or vigorous activities where you actually, your heart beats faster than normal, such as water aerobics, brisk walking, hiking, cycling, etc., or even harder things. And eventually, if you feel good enough, you can indeed run a marathon. Well, what is the benefit of physical activity in cancer patients? Because it's very good to say, hey, you should do physical activity, but is there an impact? Oh, here you cannot see the reference because I think because it's in white. But so studies have shown that actually cancer has negative impact on fatigue, physical deconditioning, body composition, treatment side effects, etc. And physical activity has a positive impact on all of these. So it's really important. Oh, here you can see the studies. So that's a prospective cohort of pre and post diagnosis physical activity. So it's not in ovarian cancer because most of the studies are, well, mostly in colorectal and endometrial and breast cancer, and then in gynecological cancer, it's mostly in endometrial cancer. We need to do more studies related to ovarian cancer. So is there harm in restricting activity? Yes, because if we restrict activity, if we tell the patients after surgery or after treatment, please rest, do not do anything. So we will actually have reduced physical activity, we'll have patient deconditioning, we'll have reduced muscle mass, reduced VO2 and cardiac output, increased risk of serious adverse events, and impact on and significant impact on recovery and overall health. So yes, there is an impact and there is harm. But when we want to put this in place, it's not always easy because there are some facilitators, but also some barriers. And most of the barriers are related to lack of motivation, cost, travel time. But also an important thing is also the lack of communication with the doctor, because sometimes, and also training of the healthcare professionals to know what to recommend and when to recommend and how to recommend, and to give them access to a network where they can actually recommend the patients to go to this facility or this facility where they recommend or they can be guided by a physical activity therapist. And we should have programs that are adapted to patient needs. So simple ways to stay active every day: take the stairs, walk at lunch, ditch the car, take the transportation because you have to walk, stretch it out, talk and walk, go chat with colleagues instead of just sending emails, walk to them to talk to them and then go back. Play when you have energy with children, and make it social. So exercise with friends and family because it increases the motivation. So small steps will induce big health benefits. And one last thing, it protects from from losing muscles and undernourishment. So it is really important because it's a cycle where if we don't eat well and if we don't exercise, we'll actually start losing muscles. So we will be less active, and it's a cycle. So we need to get out of it. And it's really important to talk about the symptoms we have regularly to the doctors. We need to ask questions, and this is the FAQ from the beginning. So you have to have frequently asked questions to the doctors. Ask them, can I exercise? Should I see a physiotherapist? Am I losing muscles? Should I see a dietitian? Do not fear of asking questions. We are here for you. What can I do for my fatigue? What could help my neuropathy? So what can I do for my sleep, for intimacy, for confidence? And we also have to ask, because we have to know that not all patients would dare ask that questions, or they might think that the most important thing is to focus on treatment. But this is actually not a luxury. Quality of life is part of the treatment. Rehabilitation is part of the treatment. So it starts early, and movement in medicine is safe. It's part of the treatment. nutrition protects strength, and track your symptoms. So the goal is to keep the quality of life and the autonomy throughout treatment. And together with you and with the healthcare professionals, we can go beyond the wall. And thank you.
Thank you very much, Hussein. Going beyond the wall is very like your personal interest, right? Hussein is one of the most sporty people in our society. So it was great to hear from you insight on that.
Thank you.
And now it's already late. And I think half of our doctors are already home with families. It's time for you, Hussein, and all of us go home as well. But before that, we proceed to check our desk. It's a closing and just we follow up what happened today during the last almost 2.5 hours. It was a crash course on ovarian cancer, not only for those interested in that, but those who are professional in that, who work with that. It was extremely useful. So we reached the checkout desk of our virtual Onco-Care unit. It's a beautiful hospital, right? We still have a lot of technical issues to work with, but we have a great team of great professionals, and that's the most important. So before we close, let us briefly return to our 3 patients. You still remember, we have 3 ladies who went with us through all this journey, or actually we did follow them. So Tessa lives with the information about genetic risk and prevention options. That's a lady with 3 children. I think you remember her. Fiona and Sophie live with a clear understanding of diagnosis, treatment planning, biomarker testing, different individualized treatment methods. And of course, support and rehabilitation. So we know a lot now about pre-rehabilitation, but also rehabilitation after the treatment. So the pathways of those patients very different, but none of them should walk the path alone. So we follow them today, and I hope that they will have, other patients will also have people who support and follow them. So we have just the key message that we want to highlight, a few points that we think are important, just to kind of wrap up. We think, or we do know that symptoms of ovarian cancer must be taken seriously, especially when they're persistent. So now we think about our patients with a bloating belly and very uncomfortable feeling. Take it seriously. Also, genetic and biomarker testing can be essential for treatment decisions in ovarian cancer. This is very basic. It becomes basic in the majority of cancers, but in ovarian cancer, it is very well-known fact. Ovarian cancer care should be multidisciplinary and patient-centered. That's what we try to do today, right? We were trying to build the whole hospital, or to go through the whole hospital from a perspective of a patient. We were talking a lot, Stephanie was talking a lot also about emotional support, caregiver support, and rehabilitation. And it's not something extra. It's a basic. It's a part of a comprehensive cancer care. And finally, access to diagnosis, testing, treatment, and support still unfortunately differ between across the countries. And that's why ENAGAGE, those who organize this webinar, matter. So patient advocacy group really matter. With this, I want to give a word to my friend, Olivia. Olivia.
Thank you for joining us today in the virtual Onco-Care unit. We hope that the patients we met, Fiona, Sophie, and Tessa, will be able to move forward on their pathways with information, support, and hope. We also know that diagnosis, treatment options, and access to biomarker testing differ greatly from country to country. This is why education, advocacy, and collaboration are so important. I would like to thank all of you for your dedication to faster diagnosis, better access to testing, and the best possible treatment and support for people affected by ovarian cancer. You are all part of one team, and together we can go further than any of us could do alone.
We would also like to thank our sponsors, AbbVie, Genmab, and PharmaEnd, who were not involved in the content preparation but kindly provided support for this webinar and online tour. Thank you all and good evening.